It is my pleasure to welcome you to the Cambia Grove and this afternoon's Fireside Chat focused on the future of healthcare. My name is Maura Little. I am the Interim Executive Director here at Cambia Grove. For those of you who have never been here before, the Cambia Grove is a healthcare transformation hub focused on bridging the gap between entrepreneurs and the traditional healthcare sector. We do this through programming, partnerships, and public engagement, all with the lens of catalytic impact in our healthcare sector. We are hosting today's event with the Bipartisan Policy Center. BPC's Future of Healthcare project, of which both of our speakers are part of, serves as a resource to policymakers to develop effective and politically viable solutions to our nation's greatest challenges. Recently, the Bipartisan's group of experts have been traveling across the country, convening leaders in the healthcare sector in an effort to support policymakers and business leaders as they wrestle with how health reform impacts their activities and people they serve. We are hosting this event in collaboration with the Bipartisan Policy Center to bring our Pacific Northwest dialogue back to Washington, D.C. during this critical time in healthcare reform. Now, it is my pleasure to introduce our panel. Today, we are thrilled to welcome former Senate Majority Leader Bill Frist, former Acting CMS Administrator Andy Slavitt, and Jan Berger from Health Intelligence Partners, who will moderate today's panel.
Thank you, Maura, and thank you all, both those of you in the room and those who are joining us virtually, for being here today. I'm impressed and want to tell you all that for Cambia Grove and the BPC to have this in such a timely time, because nothing is happening in the other Washington, D.C. today. Some of the rules of engagement for us. We're going to spend about 30 minutes, and I'm going to take the moderator's prerogative to ask our two esteemed guests a couple of questions. And then we are going to open it up to you all. You don't get to sit back and be passive. We ask you to ask your questions, be thoughtful, be concise, so that we can hear from our two guests. Those of you who are joining us virtually, you too have the opportunity to ask questions. So definitely join in. We're going to get started here by saying, as I started, there are several actions and activities going on in Washington these days. They are ongoing and they are fluid. But I would like to ask both of you your general thoughts that the group here can take on. This is a multi-stakeholder group, but all of us know that health and healthcare is very personal and very important to each of us. So can you share with us some of your thoughts about what is going on in Washington and how people here should frame it and think about it today?
Okay, good. It's great to be with all of you, and we'll keep things fast moving and to the point. These sort of discussions give us the opportunity to really respond and interact in ways that can be special, and let's make it that way here over the next hour. So the big thing going on is the United States and the American people have a contract. We have a social contract in this country that is interesting. A lot of people say, well, in America, we don't really have social contracts like Switzerland or Germany or France or England. And in truth, we do. Our social contracts are very different, not as complete. They're K through 12 education. They are Medicare, I'd put into it. Medicaid, I'd put into it. And we have a social contract. And with the Affordable Care Act coming in, that social contract, under the leadership of President Obama, who pulled off what other people had tried to do for 50 years, that social contract was extended to peoples that are more vulnerable, that the rich and the wealthy and the well-to-do generally do pretty well in America and get pretty good care. But let's extend that social contract down over to more vulnerable populations. What's going on now with the elections and under the leadership of President Trump, and with support of the Republican leadership, there's a pulling back of that contract. And you can debate, it depends on where you are. You're Republican, Democrat, what are you thinking? But that's what's happening in the big picture. and you're seeing it play out literally as we're sitting right here, is you pull back, how much pullback is acceptable to the American people who has reflected its voice in the leadership that's there now. So all this can be done, and it can change from time to time. So I won't talk about the Washington. Now, Andy, you can take that since you're the Washington man here, and I'm out of there. But that's generally what we're seeing. Thematically, I'll keep coming back to the fact there are generally 3 or 4 big underlying trends that no matter what happens today, no matter what happens next week, our healthcare delivery system, and more importantly, the determinants that determine the health of the American people, are going to keep moving in that direction. We can, with sort of this gentle hand or heavy hand, we can accelerate them, we can try to pull them back, but they're going to continue as we go forward.
So let me compliment those remarks in a couple ways. And first of all, we are thrilled to be here and to interact with you. Generally speaking, if you're talking to a Democrat or a more liberal healthcare person, they're probably going to start by talking to you about coverage. How do we cover more people? How do we get more people in the system? And generally speaking, if you're talking to a more conservative healthcare policy person, they're going to talk to you about how do you make healthcare more sustainable? How do you lower its costs? How do you make it more economically sustainable? Now, Democrats could do a much better job talking about costs because they can't achieve that dream of covering more people at the current rate and speed of costs. Mm-hmm. And Republicans could probably do a better job proving that they're not always making cost a fig leaf for cutting the size of the system, but indeed that they're really looking to make a system that works and more sustainable. And within that framework and with that parameter, you would hope that there are people of good minds that could come to a debate and get to better policy outcomes. I would observe that what we have today is a set of policies, in part because they were probably brought together hastily, that really don't achieve either outcome. They don't cover more people, and they don't bring down the cost of care. But we have, I think, a political dynamic, which I think we're all observing, which is people being reminded of the year 2014 and all the things they committed to in 2014, 2015, and 2016. And I think for those who are home in their district interacting with folks, they're saying, well, hey, what about 2016, 2017, 2018? Where do we go? And even to the point where there are some element of what we're considering that goes all the way back to 1965, that takes the social compact back further than even President Obama to Johnson, and says this commitment, this more open-ended commitment from the federal government for low-income people, for people with disabilities, we're going to draw a line there. And we haven't yet had a public debate about that, but that's very much going to be under the table this week. I'll make one more comment, which is a comment that we just talked about back there, which is, okay, well, what would a good debate look like? If we're having this conversation again in the mid-2020s, and I would say we tend to be on about a 10-year cycle. God knows we can't do it more often than that. It would kill us all. But when we're having this debate again in the 2020s, which we will, what will we want to be having it about? And how will we want to be having it? And what do we need to be doing now? And I would argue that if we're not having a debate about something where we have built some sort of consensus that at least 60 to 70% of the American public understands and supports, and that where stakeholders don't come to the table within a year of the vote fighting for the scraps, then we are going to be having another suboptimal debate. And so whether you believe in a single payer future, or whether you believe that the free market's going to solve all our problems, or whether probably like us, you believe that there's elements of both that need to work together well, those are the things that we're going to have to get back to if we're going to get our system right. And in the meantime, the great news is we don't have to waste those 10 years because the states have so much they can accomplish, and I think can show the way for the federal government when we take this up again.
You just talked about suboptimal debate, and you talked about you used the word consensus. I want to take just a moment before we move forward to looking at the health system and innovation, and I'm going to ask Senator Frist to take us back a few years to when you were leading and talk about how the decorum was different then than today. And if you were to give some advice to those who sit in those seats today, what would that advice be?
You're setting me up dangerously. You know, we all go back and say it was always better in the good old days. So you have to be really careful. But I think Andy mentioned the way he thinks of it is sort of this every 10-year cycle. And when the debate occurs, it's very, very critical how well prepared. I would argue this debate right now is thrust upon the American people by elections, and Republicans are not prepared. Democrats are not prepared either. Everybody thought the big stuff had been done and kind of moved on. But if you do that and you go back 10 years, it was a different time. It's still a very partisan time. Remember, I ran the body of the United States Senate. People have been shot on the floor of the Senate and beat with canes, and we're not seeing some of that, but that's in the old days too. But I will say the last big bill that, as Majority Leader, which is not a, as you can see with Mitch McConnell and with Harry Reid and with Tom Daschle, other leaders before, that it is a political position. But we did have the advantage in what was called Medicare Part D prescription drugs, the Medicare Modernization Act, which was about 10 years before the Affordable Care Act was passed. And at that point, I had the advantage, which people don't have, to have a Senator Ted Kennedy, who clearly very different than sort of my more centrist views, and believed in not just universal health care, but single payer in the most sort of aggressive sense. And but I'd have him right there, and I would be right here. And he would say, Bill, I'm not going to vote for this thing. You're putting $400 billion in. You put $800 billion in, and I might vote for it. But I'll sit here and work it through with you. And I was with his chief of staff 3 nights ago, and he came up, and we sort of recounted some of those stories. That is something that is lacking now in terms of the body of the Senate. They're sort of called bipartisanship, and obviously we're part of the BPC, the Bipartisan Policy Center sort of effort. That bill, which was almost a $500 billion bill, this was sort of, Affordable Care was about $1 trillion bill, but this was a big bill 10 years before. And by the time we passed, we didn't lower it to a 50-vote threshold. A 50-vote threshold says automatically, I'm thinking partisanship. I don't need Democrats, I need Republicans. And that's what President Obama did when he passed the Affordable Care Act. And he said, I don't need Republicans, I can pass this with 50 votes. And so it's both sides, not porting blame. But once you lower the threshold there, by definition, you're walking into a room and saying, I don't need half of you. If you keep the 60-vote threshold, you need bipartisanship. So in that bill, about half the size of the Affordable Care Act when I was leader, it wasn't because I was some great leader sitting there putting things together, but it basically said with the 60-vote threshold, I needed to get votes. I needed to compromise before going to the floor today, voting on a bill, a motion to proceed, and nobody knows what it is. I couldn't do that. It wasn't even it wasn't a possibility. It wasn't on the table. So that bill passed with 12 Democrats voting for the bill, which was Medicare Modernization Act, a bill about half the size. That climate is clearly very different today. So I'd argue as long as you use these 50 vote thresholds, you have no opportunity. And it's not that people are better or are worse. It was people were prepared a little bit better. They had time to think, to negotiate, and then they were forced to compromise, still being very principled, by both staying in the room with that discourse. Let me just close and say we can return to that. It is very simple to return to that. The American people want that. The American people will demand that. They'll demand that in the elections, electoral process. We need to stay there. And it's as simple as having the President of the United States saying every Friday, I want 3 Democratic leaders, 3 Republican leaders coming to my office every Friday. Not just on one issue, but every Friday. When the American people see that, they will respond. President Trump probably will not do it. He doesn't have the wherewithal. He doesn't have the depth. He doesn't have the sophistication to do it. He doesn't have the experience to do it. President Bush started doing it, but he lost it when the war hit. President Clinton did it well. President Obama was miserable at it. But it's that simple to see the revolution that's happening in Washington now once again turn back.
Andy, do you have some thoughts?
Well, I think in some respects, how often I've wished that we could have had something as similar to what happened that Senator Frist at the time passed and was implemented around Medicare Part D. with the Affordable Care Act. I think because what happens with major legislation is you get most things right, you don't get everything right.
Yeah.
You spend some time learning, and you realize, so when we drafted the bill, we left out left-handed people in Northern California who don't take their medicines on Wednesdays. And you have a technical fix, and you fix it, and everybody does that. With the ACA, if we had been talking about the things that we were observing right away, that before they became fires, when we said, you know what, there's smoke there, we can make sure this is a competitive market, we can make sure the market's more stable. We can even do it on terms because it was a Republican majority that are more state and innovative centric. We would have been managing our stuff along the way. We just decided we were going to do no maintenance. The Republican Congress said, you know what, whatever you wrote, it better be perfect. Because if it's not perfect, we're going to exploit every flaw. Furthermore, and Senator Rubio was proud of this, so I don't think he would mind me calling him out, but you know what, even if he did, he decided that he was going to defund the rate stabilization fund. And so I think everybody has to look at themselves. I think any Democrat who says that we wrote the law perfect and it would be running perfectly if but for the Republicans is not telling the truth. They're not being intellectually honest. And any Republican who says that this market's unstable and the law's broken and it wouldn't work has to look at themselves as well. I think there are things far beyond my depth to understand that are causing us to send people to Washington who just won't do those things. And if we learn, there's a lot of different lessons we can learn from Trump, including oversteering the other direction. But I think the thing that I will tell you, I've been around and done like 16 town halls around the country with ordinary Americans. People so desperately want what Senator Frist said. They so desperately want people to come to D.C. that are not willing to make them table stakes in a poker game. And until they have that feeling, we're going to have this very volatile situation in a relationship between us and our politicians and our elected representatives.
You've used the word discourse. We have a group of very diverse people in this room. I'm going to ask you all about innovation, because this is what this space is about. This is part of what this conversation is about. The healthcare system is evolving in order to meet both the access and cost issues that have been brought up. I first want to congratulate you, Administrator Slavitt. I never thought we'd get the most innovative areas within healthcare coming out of CMS. CMS historically kind of was made fun of for not being innovative. You brought innovation to an area that is not historically innovative.
I agree with you, but it wasn't me, but thank you, yes.
No, it was you. Go ahead. I'm with you, Jan. It was him.
There you go. And Senator Frist, you both, whether it was in your period of time in healthcare as a physician or in Washington, again, you were an innovator. What would you say to this group here as we are in a period of uncertainty? We are both traditional healthcare people and organizations and companies that traditionally did not sit within the circle of health and healthcare. What's the advice you give this group today as we're all moving forward looking to improve health and healthcare in this country?
You want to go or you want me to
Sure,
start?
I'll take a shot.
Go.
So, look, I think it's really important that we decide how and where to focus our resources as we innovate. And here's what I mean. Having overseen Medicare and Medicaid, I can assure you, you can take this away. America's problems are not with 67-year-old joggers with 2 Fitbits. They don't need a 3rd Fitbit, okay? America's problems are with the woman who lives 2 bus stops from her dialysis center and probably 2 bus stops from her nearest grocery store. And when she misses the 2nd bus, or she has to miss work, she could go into renal failure and spend 100 days in the hospital. And the causes had very little to do with health care. What's excellent and exciting news is that if we focus our innovation not on product innovation and gadgets, not on buzzwords like AI, not on things that necessarily investors are extremely excited about, but if we invest it where we are spending an awful lot of money for not a lot of good outcome, frankly, with people who are older, poorer, and sicker, I could tell you that if everybody in the country had access to the same healthcare experience I have, we would be just fine. We would be just fine. So we've got to focus on the people who need the care that need it. Secondly, let's just put it on the table. We charge each other too much for healthcare. There's a lot of reasons we do it, but we're stuck in the cycle of it. It's unit cost. It's the cost of everything. It's because I can tell you I have heard from people across the country, and I talk to them, and you have as well, who have gotten that prescription for their child and walked out of the pharmacy because they couldn't afford it. I've talked to a woman who takes her medication, her maintenance medication for mental health, every other prescription, and talks about her bad month. I've talked to people who have had kids go into the ER in hospital and how that's financially changed their lives for the next 14 years. One event, broken arm, 14 years. So we charge each other too much. Some of the reason we do it is because healthcare is our job sector, and we're addicted to the jobs that it creates in this country. And so it's a very hard cycle. But we have to figure out how to repurpose, and I think that's the third thing I'd say is everything I see us do well, it's when we deinstitutionalize, it's when we take care of people at home, it's when we unite families, it's when we give care and the budgets over to families to take care of their families instead of institutionalizing them. And we begin to save money, and we begin to get more humane. And that's where technology, coming back to my first point, can help us, because you need good technology and data to make that dream come true. So I just want us to focus on the right places and bring that entrepreneurial energy there, and that's how we'll start to make progress.
Senator Frist.
So I mentioned forget Washington. Washington's important, but forget Washington. But I say forget it, and you're exactly right. CMS, for a demonstration project when I was in Washington as leader, it would take about 8 years to do it. You'd plan it, you'd get it, you'd play with it, you'd implement it, you'd get a result. It's an 8-year cycle. Well, the half-life of medical knowledge is probably 14 months. So it was crazy. And CMS turned that on end. So again, this is sort of applauding what our government does, and we can't dismantle that from an innovative standpoint. I am probably, so I'm a heart and lung transplant surgeon. That's what I did, and I did it at a time where it really wasn't there. It really wasn't a possibility. Nobody ever done lung transplant. Nobody ever done a heart lung transplant. But jumping into it at the time and getting the smartest people and a willingness to innovate with a commitment of resources, today lung transplants are routine. Heart transplants are routine. I do 150. My center now has done 2,000 of them. They're routine. And so these things that are seemingly impossible can be done. And healthcare is complicated. And if you say we have to do it in the same way that we've done it, it's impossible. There's not enough money. There are too many, 30 million. There are going to be 50 million people uninsured probably here shortly. There's not enough money to promise everybody everything, and there's not enough money if you say you have to deliver it in the same way. So I think, Andy, you're exactly right. We charge too much, but no doctor is going to say, I'm going to lower my rates to save America and that sort of thing, and no hospital is, because they're barely going on. So we've got to change the way we're doing business, and the way we do that is what Seattle sings in. It's what you sing in, and that is empowerment of individuals through consumer engagement in a way that gives them the information and the tools they need to shop wisely, to be smart. 2 choices. Let them choose based on what is valuable to them. Obviously, they need the resources to be able to choose. That's where I started back with this social contract. We have a responsibility. I do a lot of work in the Southern Sudan and many African countries. And no matter how poor people are, they want dignity, number one. Number two, they do want to be able to choose what's best for their kids. And number 3, they're willing to pay. If they can't pay for something, when they get better, they want to go work in the field behind the clinic. So we got to get back to learn what other countries think in terms of community health workers. Not everybody has to be Bill Frist, heart and lung transplant surgery delivering health care. We need to use technology in a way, again, that this part of the country sings in, and telemedicine, we've had discussions over the course of today. You do not need to get in a car at 2 o'clock in the morning if you have a bad, very bad allergy or even bad chest pain, if the alternative would be to pick up the telephone with 8 minutes, talk to a board certified doctor in your state for a charge of $40 versus $2,400 in the hospital. That takes change in the way we do business. It means you can't let doctors have these cartels and say, no, telemedicine's going to stay out of Texas until you establish a bricks and mortar relationship, and only then after that can we use it. When you have 80% of the counties there have fewer than 3 primary care physicians, it can't be done. So we need to think about how we do medicine, deliver medicine. And Andy, I think he said it, America has led in terms of molecule, pharmaceutical, science, good innovation. We've excelled in imaging and procedures and devices. We are the world leader. We are the worst in where of the $3 trillion in healthcare, or the $2.3 trillion are spent in delivery of how an individual accesses a hospital, a clinic, a telemedicine call, a nurse. We fail, and that's where the innovation can be. And it's going to happen through empowerment and tools we didn't have before. It is big data. But big data has to be shown to have value, and who better to do that than the biggest big data people in Seattle. We have artificial intelligence, and within that, you have machine learning, a subset of that. Within that, you have deep knowledge. Who excels in America are, I'm implying Amazon and Facebook and Google. What I really mean are the individual entrepreneurs who have it in their head, and teams of people who are coming together with competition of how to make Alexa. I have OK Google and I have Alexa. Alexa I had to put away because my wife got so jealous of me calling Alexa, Alexa, help. And so I'm back on OK Google for that reason. But at the end of the day, that voice of what I need versus going to a hospital, that immediacy is there through the technology itself. So what this Grove is all about of convening just like this, and then identifying problems, and then coming up with solutions, and then being a catalyst for that change is really what we need to do in healthcare today. That has nothing to do with the United States Senate. It has nothing to do with the Majority Leader. It has to do change the way we do business, empowering 300 million consumers and not 100 senators to be playing. It does mean government has to take care of the vulnerable, has to have the social contract, has to empower, has to facilitate risk determination. But if we do that, there's no more exciting time than ever when we can do palliative health care in a way unheard of in a fee-for-service system. If you want to wrap 5 people around an individual who's going to die in 6 months, in a fee-for-service system, you can't do that. You have to pay all 5 of them, and they aren't communicating. There's no electronic health record. But if you innovate and you go and you pay a bundled fee for those 5, and you have the appropriate analytics to realize to target you and not promise it to everybody else, but just you, because you're the person, I'm going to die in a year. Then all of a sudden the analytics and big data for identification of who you are, wrapping people around because of innovation in the delivery system, it doesn't cost that much. I better stop.
It sounds to me like there's great opportunity outside of Washington, as you said, in states, in communities, in local organizations to come together and ideate. With that, I want to start by opening it up. Are there questions of our audience, either a virtual audience or actual audience, that'd like to start?
This is really a question for Andy. So I just came back from Japan meeting with some Abe's people who told me repeatedly that our health system is vastly inferior to theirs and actually to many around the world. How did that happen? Because 10 years ago we heard that we had the greatest health system in America, in the world.
You know, I just did an interview with the biggest TV station in Japan, and before I started, they're about to put on the camera, the anchor says to me, I swear he says to me, "I'm sorry about your president." So, which I thought was he did it in a very polite way though. You know, I think that I won't single out Japan, but I will say this, and I think Dr. Frist will have it probably.
Wait, he's not really a Republican, though. All right, keep going. All right, keep going.
Yes, but he's letting the Republicans run the town. He is. Okay. Well, that'd be fun to do that later. Focusing on your question now. What I find very striking, and I think we both talked about this, is we underinvest in keeping people healthy, we underinvest in primary care, and we overinvest in having people show up once they're past the point of treatment. Furthermore, the rest of the world would argue overinvests in social services, and I think that really pays off. Now, we are looking for quick fixes we're looking for quick fix solutions. There are none. The quick fix solution is just a 3-letter acronym and then another 4 years of recycling through that. If we really are serious, though, I believe what we have to understand is that you have to solve the root cause of the problem. I'll put this in the context of innovation. So I've had a chance to have people show me a lot of different things since I've left, and people know the things that I'm most interested are innovations for vulnerable populations. And I took a look at a company the other day, I won't mention the name, but they have y'all ever passed through a drug rehab clinic in the middle of the city where lining up outside are people that are strung out and homeless, and it's a pretty abandoned building. It's a pretty tough part of town. Well, they're building clinics where they're giving Naloxone, and clean, beautiful, great experience. When people are inside, they're talking to them about their housing situation, about employment, about social needs, and it's a totally different experience. This is a commercial, for-profit kind of company and idea, but they're going at the root causes. They're taking the same money, probably from Medicaid, or from the commercial payer, from wherever they're taking from, and instead of just focusing on the fee-for-service, getting people in and out, they're actually going at root cause and root cause problems. And I don't see how we get there if we're not willing to expand our thinking beyond just providing services to going all the way upstream to look at all the causes. And that's going to mean looking at adverse childhood events. It's going to mean looking at how babies have a healthy start. It's going to mean looking at making sure we reduce unwanted pregnancies. Our country has to be able to afford to invest in those things, in my view.
And I'll just be real quick. Number one, the social contract of Japan and other countries that I mentioned earlier, forget healthcare, from a social, moral, healthcare equity standpoint is greater. All sorts of reasons on the founding of America and the pioneering spirit and independence and all that. It's just greater. So that's number one. Number two, health of the population is only sort of 15% determinant on Vanderbilt hospitals, Cambia insurance, hospitals, doctors, delivery. And the big thing is obviously the 40% behavior, and you got your 30% genetic, and with Japan, there's probably a difference there, in terms of living longer, it's probably in part genetic, and 15% in environment and the like. But the big thing is you've got only 20% of the healthcare system, but if you look at the healthcare system, we spend twice as much and we only have our outcomes half as good. So then you have to look at the social determinants, the 40% of behavior. And it's exactly as Andy said, and the data is this. For every dollar that we spend on the healthcare system, the insurance and the doctors and all, other countries, Japan spends $2 in social services, housing, education, food, safety issues. $1 healthcare delivery, $2 social services. In America, for every dollar we spend 50 cents in housing, homeless as I walk around here, and food, and the social determinants of health. And so my answer would be, yes, let's fix the system, let's get the equity there, let's do the healthcare delivery reform, let's innovate, and let's use technology. But equally important is going to be smart investment in communities and the social determinants of health. And that is going to be equally important, I think, for our leaders to develop as we go forward. Somebody back there.
We have a question from one of our live stream viewers. Three of the major drivers of healthcare costs in the U.S. relate to the legal costs of medical practice, the soaring costs of a medical education, and private interests in health insurance. How can we effectively begin to impact these three levers when business interests and thus political interests are so heavily invested in them?
Okay, what's the question? What did you hear?
How do we affect healthcare costs if we don't deal with, I think, the three things you did: tort reform, the cost of medical education, and
Private interests and health insurance.
the private interest of insurance.
All right. Sounds like a good one for you.
Why don't
Take
I,
one or two, but I'll tell you.
why don't I start?
Yeah,
And then before I say, then when you think of something really smart, you just cut me off.
okay.
I mean,
I got mine. You go.
look, you can't. We all wish we could, but we can't reinvent the system from scratch. So we have to deal with the system we have, and there are a lot of entrenched interests. I think half of this question, I take half of this question as how do we deal with the entrenched interests when we want to make changes, and I take the other half of the question as the sort of the specifics. And all three of those are policy drivers. I wouldn't argue that they were the three of the biggest, but I would say psychologically, tort reform is a psychological barrier.
How big is tort reform? A problem?
You know, I've seen one thing which says it measures at a couple percent, but I've seen another thing which says that the conservative medicine could be up to 10%. But it's in the single digits.
Is tort reform a major driver of healthcare costs, do you think?
I wouldn't call it
I would
major.
say no. I'd say
call it
it's a direct cost, probably $15-20 billion in the aggregate with all the defensive medicine, and I do it. I get MRIs for people coming because I don't want to be sued. But in the aggregate, it's probably 200 billion. And the big thing is it trends up and down, and right now it's not. About every 10 years it becomes a big issue, and it's not a big issue now. Number two, what else? What was one of the other things I mentioned?
Medical education.
Yeah, is a cost driver.
The cost of education. I don't know if that's a big cost driver, but I would say the federal government spends a lot of money on it. We ought to get what we pay for, and we ought to be making sure that we put people in places that we need them. If we're going to pay for their education, and we ought to make sure. Look, I'm not a big social planner type. I'm a centrist like Dr. Frist is, but I do think if we need more primary care, then we ought to be setting policy that drives us in that direction. If we need more heart and lung surgeons, we ought to be setting ourselves in that direction. If we need more geriatricians, which we desperately need, or psychiatrists, which we desperately need, we ought to be floating in that direction.
And I'd basically say we are educating the wrong kind of physicians today. And the fact that we're even talking about physicians is a mistake, because we need to look at nurses who are out there today. We know we are about 140,000 primary care physicians short over the next 10 years. So somewhere policy has to make that decision. Again, you don't want to do too much sort of architectural control from above, but policymakers have to address that. Number two, we need to make sure that we don't have such rigid definitions that people can't really practice up to what they're licensed to practice. And that means doctors have to kind of turn over some of this traditional control to ancillary personnel, to community health workers, empower people who can do jobs that historically doctors have said, no, that you can't do.
That's right.
I don't think that's a big overall cost driver, but in terms of reform within the system, there's huge reform that needs to be done. And then the third is that whole use of technology. Who can use technology? And telemedicine, that we've already mentioned, is probably the best example to get around that.
And then let me just add one thing, which is the other element of the question, which is how do we deal with entrenched interests when we make changes?
Yeah.
Okay, and I don't know if you've had this experience. I had it at CMS probably every day. Somebody would come into my office or an outside meeting. They'd either be from the hospitals, be from the pharmaceutical industry, they'd be from the health plans, whatever. And I spent my whole career in the private sector, so I knew where they were coming. And they would explain to me in the most articulate way possible how everything that was happening was somebody else's fault. And if I was talking to a pharmaceutical company, this is such a core skill, they were able to tell me perfect order how the PBMs were screwing everything up and how the health plans were at fault and how hospitals and the drug program in hospitals were terrible. And of course, if the PBM would come in an hour later, they would tell me how the pharmaceutical companies were all at fault, the health plans are at fault, doctors the same with hospitals, hospitals the same with doctors, and health plans, and everybody hated health plans. And so by the time you get through with these meetings one cycle through, you just want to stop and say, hang on a second. Just tell me what portion of the problem is your fault. Is it 0%? Is it 1%? Is it 5%? We're not good. We're very good at protecting our own interests. And I think I find that once we make $1 in whatever industry we're in healthcare, we feel we're entitled to it. And which is only going to do what? Drive costs up. Because you can't take $1 away from anybody, and people are good at protecting and fighting for it. So that is something that I think because it's become such a big part of our economy, as I say, we're addicted to the jobs, we're addicted to those companies, not easy to shake ourselves from those things, but we have to have an honest conversation. And I tried to do this when people would come into our office, and understanding that everybody's got a responsibility. As far as I'm concerned, if you're seeing Medicare patients, Medicaid patients, I needed to do two things. One is to thank you, because I know how hard it is. And the second thing is to tell you, you're a government contractor. You're taking taxpayer money. So guess what? We've got an accountability here together to deliver value, and let's figure that out. There are whole industries that over-dialysize people, that let people get sick before they take care of them, like the dialysis industry, but I not just want to pick on them. I think there's other industries that have, I think, lost sight of why we are paying them money. And I think we all have to get together to fix that.
And the entrenched interest, things are getting much better in Washington, D.C., and it's the internet, it's the power of mobile technology. The last elections, in large part, and President Trump and Obama's election did the same thing, the power of the individual in using information that's transmitted to an individual who now has voice in Washington. President Trump's policies, as you can tell, I'm not a big fan of many, but the one thing he has done is opened up communication directly to the American people. It doesn't take a lobbyist in D.C., it doesn't take a law firm in D.C. The empowerment and individual Senate offices connecting now with advocacy groups, with real patients, it can be done. And as Majority Leader of the United States Senate, if I got 350 letters, that would move me. People would count the information. And that's good, but the 350 people who were active enough to write me, now millions of people can actually write, and it can have an impact, bypassing the DC establishment. Now, President Trump uses it, but he has introduced, just like cable TV when it was introduced, it changed politics, television changed politics. He has introduced, and President Obama did it in this election coming on, but communication directly with advocates, directly with people. Now, he's tweeting and not doing Facebook, and therefore he's projecting, and in the old Trump way. But once we convert this social media to true engagement with the appropriate curation, you start bypassing many of these entrenched interests. And on the insurance end of things, Cambia's a little bit different. I'm not here to sort of speak one way or another, but true insurance, if it's just insurance, that doesn't take a whole lot to do that. If the insurance industry does not address a couple of things, the huge administrative costs that we have in healthcare today, the 18% that can be squeezed out. Medicare does a good job there, but it has to be squeezed out. But unless the insurance industry modifies to do something more than just taking money and reimbursing people automatically, obviously 5 or 10 years from now, with the empowerment of the internet and with digital media and communications, it's going to be really hard to justify what an insurance industry does. And therefore, you can see most are getting into quality issues, into value issues, into outcome issues. Once you get the outcome issues out there, and then you give the empowerment of transparency and pricing, which we haven't talked about, and then you get an empowered consumer, it's going to do a lot more in terms of momentum, thrust, change, innovation, getting costs down and value up.
I want to thank you both for being here today, and I want to thank Senator Dr. Frist for your discussion about social contract. And my question is, a two-part question. The first is, do we need to have the conversation about, and if so, when will we have it, about two things? One, I believe that there's a political divide between the discussion of, is health care a right? So that's the first question. Then the second one is, when will America be mature enough or able to have a discussion about what amount of resources do we want to put into end-of-life care, which I've seen in hospital work is a tremendous percentage of our healthcare delivery costs. So that's my two questions. Is healthcare a right? Are we going to have that discussion? And when can we ever have a discussion about end-of-life care and what we're willing to do to treat end-of-life care?
You want to take either one? Or?
Go ahead.
Well, yeah, obviously you know where I stand on the right. The right, it's easy, all these things have to be framed right. Family planning is a huge issue. I get involved in all these issues, but family planning is a huge issue globally. It ends up being an abortion issue, it ends up being a right-left issue. Once you change big issues, family planning globally, that's one of the biggest killers. I do HIV, AIDS, malaria, and PEPFAR stuff, what I do. But the family planning issue probably causes a lot more death than all of those combined. So how do you get that language right in Washington, D.C.? Once you get the language right, it comes back to how you have a conversation and discourse. And so what we did through a small foundation, Hope Through Healing Hands, and we worked with Melinda Gates, who is good, but she uses family planning. We changed it to the healthy timing and spacing in pregnancy. It's the same thing, exact same thing. Once you use that language, all of a sudden you bring people out. I mentioned that, and great headway is made, although Trump just cut it the other day. So I got to work on that one now. But great headway is made in terms of discourse. Understanding is an issue, and I can talk it and put HIV, AIDS, PEPFAR, Zika, family planning, but I don't use those words, and all of a sudden it's got the parity. And I say that because the right discussion is a good one to have. Once you convert the words to a responsibility discussion, and you're saying the exact same thing, and it becomes much easier. So I think that debate's an easy debate. I mean, you can see I led the Republican Party in the highest legislative body in the free world, and you can see where I am on the social contract issue. So it can be done.
My auntie in Morristown says you were a good, she never voted for you, but you were a good citizen.
I hate that when people say they never voted for you, but that's all right. I always try to. The end of life issue is huge, and you're the expert here, but probably of the Medicare dollars that Andy was responsible for, probably 30%, you can correct me, in the last year of life, but something like that. And this is where the innovation and delivery reform is, and this is where the foundation here is the leader in the country on it. Does it have to be? Because once you have the discussion, you're not in an intensive care. You don't want to die in an intensive care unit. You do want to have that discussion with your doctor, so you get rid of those barriers. So you have the hospice world, which is pretty settled out pretty well, but the problem with hospice is that people get there for the last 7 days of life, and the expenses are in the last 8 months of life, and the last 14 days is probably average in hospice, but it gets late. It should be 40 days is probably appropriate care for those of you in hospice, but it doesn't happen. So really you start looking at the palliative care world, and again, it doesn't matter, but conceptually say the last 8 or 9 months of life. On average, the last 9 months of life in the Medicare population costs about $68,000 over life. This is on average. Some are millions and millions and millions, but the people who end up in hospice, if you look back, $68,000. Appropriate care with better outcomes when it's measured, higher satisfaction rates, more appropriate discussions, and you have documents filled out, is about probably $32,000 to $33,000 appropriate care. And so it's not so much the discussion, should we not spend money at the end of life, because the money is being spent because it's being wasted. It's chaotic. It's 13 different prescriptions. It's in and out of the hospitals in the middle of the night. There's no continuity of care there. But it's you're changing the system so that you give a higher quality, a higher value of care, and the data is just what I gave you. It's about 50%. Why? Because if you have that continuity there, you have somebody to talk to. You've had a discussion. You don't rush back into the hospital in the middle of the night. So the discussion, because listening to you, it's like we shouldn't spend money at the end of life, that we should spend it up front. And I think that's sort of an incorrect, I know you didn't say that, but it's the incorrect framing. If you just had to stay the way people used to think, let's don't spend as much money at the end of life, let's take that money and spend it up front, and everybody's going to be happier. That's not necessary. You don't have to go to that. At least that's just the way I think about it.
Plus,
and I think,
plus all the money it costs to pay the death panels.
yeah, and that was, that's again.
They're expensive.
Yeah, and the death panel discussion was an interesting discussion, and it killed the palliative healthcare field for 10 years.
So it was interesting. We had, as you may remember, we introduced the first code to pay people to have discussions at end of life, which was this first step. But the discussions inside the administration were absolutely grueling because
That's
we
interesting,
were, the debate was gnashing, and I remember we went and we rolled something out and we had done it well, and HHS, the people in HHS desperately wanted to do this. And everybody was told, look, when you do it, we're going to take such huge political heat, and the White House was cautious, and so we came to the White House after we did something, I forget what it was, it made them very happy. We had just done something that made
And
them
this
very
is
happy.
just all reimbursement for the discussion about end-of-life issues.
This is just paying it, yeah, exactly. So doctor could have the conversation. And they said, I forget who we talked to, we were at the White House in the Roosevelt room, and they said, you did a great job on this, thank you. And Secretary Burwell said, we want that code. And they said, okay, you can give it a shot.
You want a code, meaning you can reimburse
The code
it.
that we can reimburse for,
Yeah.
which was essentially people were going to view as the tempest in the teapot or what have you, and it got things rolling. But what's interesting to me is, that's just an anecdote. We spend 1% of our GDP in the ICU, 1% of our GDP, and if we've all had loved ones in the ICU, it's not a place you want to die. It's just not. So you think about those numbers, you think about that experience, you think about that focus, it's exactly right. And what I tended to think about, very oversimplified, was Medicare, if we could focus on improving end of life, that would be a tremendous value. Medicaid, what you were just saying, if we could make the beginning of life work better, if we could reduce unwanted pregnancies, if we could help women carry to term, if we could make those first 5 years A+ for kids, we get people off on the right start. So, it's as with everything else, we've got to underinvest someplace, overinvest in others. Your other question about should healthcare be a right is interesting, because the country, without knowing it, has been having that debate over the last 6 to 9 months. And I can't tell you how often I hear that conversation and get asked to talk about that question. I was on a right-wing radio program the other day with a right-wing radio host. This is how he describes himself, so not being disparaging in any way. And he says to me during the commercial break, I'm for single payer. He said, I'm sick. He said, I'm so sick of this. He said, now that I know all of the hands in the pot and all that stuff, he goes, screw it, I'm just for single payer. And he said, and I'm about as right-wing as you're going to find. And it's interesting. Now, something else always sounds better when we're looking at the problem we're looking at now. Okay, so let's just be a little bit sobered by that. And I always think it's good to remind people that we have to find a way to pay for the things we want, and that may change people's. Do you like single payer and this tax increase? I think that's a fair thing to ask people. But here's the opportunity. Here's what I'd like to see happen. I'd like over the next 5 to 7 years, because I think it's going to be that long before we're having that happen at a national level, 2 things to happen. One is, at the state level, we really try it out. We have a Medicaid buy-in opportunity in Nevada. The governor almost signed that. With some more real work with the hospitals and others, possibly that could happen. It could happen somewhere else. So we should try some experiments, see what happens. State level, that's I think what state's for. And then the second thing is to get to a language that unites us around making how we think about healthcare in a universal way, then divides us. The Medicare for all and single payer pieces appeal to a lot of people, but they won't appeal to others. And secondly, they all mean different things to different people. So we ought to be smart about it if we really want it. We ought to be having a dialogue about what it is we want, about what those trade-offs are, and what that language is, and what is it that we have a right to. I would say we have a right to a regular source of care and to not go bankrupt when we get sick. I don't think we all have a right to every heart and lung surgeon at Vandy when we need them. But I think there is something we do have a right to. I think that's the conversation that we should let play out over the country. We should leave Washington the heck out of it. And then at some point in time, after we make some progress at the state level, if the people who really care about this issue really want to see progress, we maybe will have built the foundation to do something more.
One more quick question.
Thank you both, and Senator Doctor. One of the things that you talked about was empowering, talking about end of life when this woman's going to pass away, that she's going to have her group of physicians around there communicating, talking about it. But you didn't mention what she wants for herself. And that, I think, is the big important thing at end-of-life care, finding out what the individual, what the patient wants, because that's where you can save a lot of money for needless care that people don't want, and make sure that they're talked to.
Yeah, amen to that. The end of life, the palliative field was a field that didn't exist 20 years ago, and I'm on the board of the Robert Johnson Foundation, and then they and Soros put it in, became a medical specialty. Then it became when I was doing heart and lung transplants, it didn't exist, yet everybody was being referred to me, and they would all die within 6 months or I wouldn't transplant them. So I got interested then and followed it very closely, because I had hundreds of patients and I was taking care of them, more than this, and they were all going to die in 6 months, and they were sent to me because they're going to die. But we could transplant them, and if I could get enough hearts, which I couldn't, they could live. And my patients from 25 years ago, 80% are alive. But some people had transplanted when they were that big, and now they're grown up, and I was just with them the other week. So miraculous. I say all of that because the palliative field is new. In hospitals and hospices, it'd be good, but where people live in the community, it's essentially non-existent today. And some way or another, using technology, using nurses, using doctors, we need to focus on the patient. Government's not going to do that. Government's going to put more money in Medicare, maybe give a little more money to hospice. So huge issue. We've talked about it, mentioned that thought leaders are here. So 3.5 years ago, what I did, because it's so obvious to do, why don't we change the payment model just a little bit? And instead of doing fee-for-service doesn't work, go talk to the head of Aetna and Humana and United and say, it's costing you $70,000, and for $30,000 we can do it with better outcomes. So that's sort of what we talked about. And what I didn't talk about is how you do it. And you're exactly right. And what you didn't add, which you should have added, is not just what the patient wants, but it's what the patient and the family around them that want. And our responsibility is to be able to do what Andy led on, is to have that conversation, and with appropriate reimbursement to do that. And not just about what we've been talking about today, the physical needs, but the spiritual needs, and the emotional needs, and the psychological needs, and the mental health needs, which is not very good in our traditional healthcare system. Now, I'd go take the time to do that, because you're exactly right. We didn't tell the complete story, but the complete story is a holistic approach, listening to the patient, and that's where Amazon and Google and Facebook are good. You can engage the patient. You know how to do it. Make it a good experience, and we fail in healthcare today. And then listen to the patient, empowered with good conversation, which government can help reimburse, do, get away from fee-for-service, do more value-based care. And if you do that, that's all innovation. It didn't exist until this company that I did. Now we have 40,000 patients, are by far the biggest in the palliative healthcare field in the virtual space. But what we're doing is saving millions and millions and millions of dollars with better care. And that has absolutely nothing to do with government, with what is going on in Washington today. It does come back to why this center is here. It is to take innovation, it's not just technology, but it's innovation in health service, marry it with this huge $3 trillion industry out there that's affected by all the stuff that we talked about, including the behavioral end of it, and marrying those two, getting solutions. So the answer is not what the guys in Washington, the men and women in Washington are thinking about now, either more money or cutting services. That's not the only answer, but it's going to all come from innovation itself. And I think the palliative healthcare is a good model. And so I'm glad that you caught me on that, because it's patient-centered model. It's not physician-centered. It's not provider-centered, and it's not government-centered.
One other thing, though, worse than Alexa is having a parrot. It doesn't work.
I hadn't come on that yet. Alexa's now in a drawer, and OK Google's on the shelf. But now I'll watch out for the parrot, too. Yeah.
Well, we've come to the end of our time. I want to thank you all, both virtually and those in the room, for giving us some time this afternoon. We know you are all busy. And please join me in thanking both of our speakers here today, both for the service you've given to this country, as well as the time you spent with us. Thank you.
Thank you. Good. Thank you all.